OB is a surgical profession, so you do have to know a little bit about the anatomy. We're going to cover only the highest yield anatomy stuff, and then we're going to use a clinical correlate to show you how it's important. Let's start off with the arterial supply. So this is the uterus, tubes, ovaries. The blood supply is going to start at the heart. The aorta is going to cross over and descend down the left side of the patient. Ovaries are fed directly from the aorta, and the aorta will branch into the common iliac arteries. We'll zoom into the uterus a little bit later. At the same time, you're going to also have kidneys that are nearby. And their venous drainage is going to mimic ovarian drainage, because blood returns to the heart via the vena cava. And the vena cava is on the right side of the patient. Right-sided venous drainage of the ovaries is directly to the vena cava, as it is for the right kidney and right adrenal gland. On the other side, where you've got the vena cava farther away on the left, because the aorta is so close, the venous drainage all drains first into the renal vein. The adrenal vein drains into the renal vein, and the ovarian vein drains into the renal vein before connecting with the inferior vena cava. Difficult to follow when I say it, pretty easy to see when you draw it. On the left side of the patient, the adrenal, renal, and ovarian veins all converge before connecting with the vena cava. On the right side of the patient, all the drainage goes directly into the vena cava. Aorta supplies the blood to the ovaries directly, and the uterine supply will be from the branches of the common iliac artery. In addition, the blood supply of the ovary travels within the suspensory ligament of the ovary. So the thing that attaches the ovaries to the rest of the peritoneum holds the vascular supply. Let's pause and do a clinical correlate right away. You've got an ovary, vein, and artery, all contained within a suspensory ligament. You can easily see how an ovary, or especially one weighted down by a cyst, might twist. And if it twists around the vascular supply, it compromises its own vascular supply. So in torsion of the ovary, you have to just get into the peritoneum and untwist the ovary, resupplying the vascular supply to the ovary. So ovary, artery, and vein contained within the suspensory ligament. You can twist about the suspensory ligament. Let's zoom in and talk a little bit more about the uterine supply. The aorta comes down and branches into the common iliac arteries. The common iliacs branch into the internal iliacs and continue as the external iliacs. External iliacs give rise to the femoral arteries as they pass through the inguinal ligament. The aorta gives rise to the common iliac arteries, which branches into the external iliac arteries and the internal iliac arteries, which then give rise, the external iliac arteries give rise to the femoral arteries once exiting from the pelvis. And it is the iliac arteries that give rise to uterine arteries. Here is the clinical correlate of postpartum hemorrhage. When you have postpartum hemorrhage, the goal is to stop the bleed. Postpartum hemorrhage is defined by 500 cc's following a vaginal delivery or a full liter of blood loss following a C-section. If you see this, your goal is to save mom by preventing her from bleeding out. Of course, you're going to transfuse and keep her blood counts normal, but what you have to watch out for is continued bleed. Before you get in there and do surgery, you're going to try medications. You're going to do a uterine massage. You're trying to get the uterus to contract down. You can use Pitocin or Methergin to stimulate the uterus. But if despite medical efforts, the patient is still bleeding, now you have to go in and actually ligate arteries. After medicine fails, you have to go in and do an exploratory laparotomy. What you go for is the arteries closest to the uterus. You want to preserve the uterus, not take it out, not kill any structures, but still prevent her from bleeding. So you're going to start with the uterine arteries. If you cannot control bleeding with ligation of uterine arteries, you're going to step it up to go for the internal iliacs. Now, if you can't stop GYN bleeding with ligation of internal iliacs, you cannot go one step farther. If you ligated the common iliacs, you'd actually just cut off the blood supply to the bottom half of the body. So the farthest you can go up is internal iliacs, because then you begin to compromise blood supply of the rest of the body, not just the pelvis. So if you cannot control the bleed with uterine artery ligation and then internal iliac ligation, your next step is total abdominal hysterectomy. You have to save mom rather than preserve her ability to reproduce. So this is the vascular supply of the GYN organs. Let's move on to the next topic, the ligaments of the GYN organs. Now this is going to be a little more difficult to draw on the board because everything is in 3D, but I'm hoping that I can show you enough so that you understand what's going on. We're going to be doing ligaments. Uterus, tubes, ovaries, vagina, pelvic sidewall. All right, we already have covered the suppensatory ligament of the ovary. They suspend the ovary in place, and they contain the vascular supply. The utero-sacral ligament, not surprisingly, connects the uterus to the sacrum. So this is supposed to indicate the ligament going backwards to the sacrum, disappearing in the back. These are very significant because these are the things that need to be cut when doing a total abdominal hysterectomy. But these are the things that look like the ureters. And so, novice OBs will try to remove the uterus by cutting the uterine sacral ligaments, but instead accidentally cut the ureters, a urologic emergency. Cutting the ureters is bad. They look like the utero-sacral ligaments. They do serve an anatomic purpose, but for your learning, recognize that these are the things that need to be cut to get the uterus out. The last one is where it becomes very difficult to understand, and that is the cardinal ligament. The cardinal ligament keeps all of the uterus, bladder, and rectum connected to one another. And side to side is not difficult to understand. Right? It connects the pelvic side wall to the side of the uterus. But it also separates as it hits the pelvic structures and forms an anterior as well as a posterior ligament supply. So let me draw two more pictures to show you two different angles. The one we have up there is pretty easy to understand. Uterus looking at the patient head on, pelvic side wall, ligament connects it left and right. It keeps the uterus from moving around side to side in the pelvis. But also this anterior and posterior portions of the cardinal ligament, now we're looking at the uterus from the side, essentially through her hip. And here you've got the bladder in front and the rectum in back. And the anterior and posterior portions of the cardinal ligament hold all of the structures in place, front to back. So the cardinal ligament is responsible for the 3D positioning of the bladder, rectum, and uterus, as well as the other GYN organs. And this becomes significant in the case of pelvic floor relaxation. That is, if you've had multiple births, especially big ones, you've moved all those ligaments around. You stretch the ligaments front and back and side to side. And because they're ligaments, once they're stretched, they don't snap back. So now all of the things that used to hold these structures in place have kind of loosened up. So you can imagine now that the bladder might fall down out into the pelvic floor, or the rectum, or even the uterus through the vagina. If pelvic floor relaxation affects the anterior cardinal ligament and the bladder falls into the vagina, you'll have a cystocele. If the posterior cardinal ligament was affected, you'll have the rectum fall through and you'll have a rectocele. If the uterus begins to descend, you'll have uterine prolapse. And these diseases are not hard to spot. You'll do a speculum exam and you'll have a structure coming in from the anterior. Since the bladder is anterior, if you have something falling into the bladder, well, you'll know that's a cystocele. If you do a speculum exam and something's coming up from the posterior, that's a rectocele. And if you see the cervix too close for a normal vagina that's coming straight at you, that's a uterine prolapse. So basically, the clinical correlate here is pelvic floor relaxation. And the pathology is that you've had multiple or large births. That have stretched out the cardinal ligament. Now, the vagina is a visceral organ. And so the symptoms of cystocele, rectocele, and uterine prolapse are not going to be very specific. The patient may complain of vaginal fullness, or for referred pain, chronic low back pain. But the most important thing for you to diagnose a pelvic floor relaxation disease is simply to do the speculum exam. If it's coming down on the top, it's a cystocele. Coming up from the bottom, it's a rectocele. Coming straight at you, uterine prolapse. And so the diagnosis is simply clinical. You diagnose it on a physical exam. And the treatment is dependent on what disease you have. If you've got uterine prolapse, you're going to need to do a vaginal hysterectomy. There's no putting the uterus back. And what you can do for the cystocele and the rectocele is colporrhaphy. Essentially, rebuild the pelvic floor. And be cautious, because a cystocele can lead to stress incontinence. More on that on the incontinence lecture. And a rectocele can lead to constipation. Before we close, let's talk about the grading of the uterine prolapse. You'll see cystocele again in the urinary incontinence lecture. This is the opening to the vagina. The normal uterus is in its position here. If you have a small degree of prolapse, that is, the uterus is closer to the vaginal opening than it should be, you've got a grade 1 uterine prolapse. If the uterus comes down to the vaginal opening but does not exit, it's a grade 2 uterine prolapse. If you've got uterus outside of the vagina but not inverted, grade 3. And if you have full inversion of the uterus, you've got grade 4. Okay, so we've talked about pelvic floor relaxation, where disruption of the ligaments cause the organs of the pelvis to move and generally move through the pelvis floor, visible in the vagina. These diseases are going to need surgical repair. And we talked about the vascular supply of the GYN organs. That is pelvic anatomy.
We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.